3, 2, 1, we start.
Hello and a very good evening to all the doctors who are viewing this program. This is the continuation of our uh, uh, foray towards the surgical skill transfer and solving clinical dilemmas. And this is the 10th episode in this series. And to grace the occasion, we have our teacher of teachers, our beloved Dr. P.C. Mahapatra, who will be throwing light on the topic of vaginal hysterectomy, the tips and tricks. So without taking much time, I would like to hand over the session to Dr. P.C. Mahapatra. Sir, please.
Thank you, Dr. Dewan and the team Juventus for the continuous program in the surgical skill transfer for the benefit of the viewers and my fellow gynecologists. And it gives a chance to me to digitally connect with my fellow gynecologists. And I'm not a teacher teaching you, but sharing my experience over last 38 years, whether good or bad, whether wrong or right, I don't know. But whatever is my experience, I will definitely contribute it till before my last breath. And that's the main purpose for which I agreed with the Juventus Pharma to continue this teaching program for that. Well, again, I welcome on behalf of Juventus and my personal behalf to all my viewers today to the Juventus Gurukul program and episode 10, and targeting on the surgical skill transfer and solving clinical dilemmas on a particular focus subject we will discuss with the blessings of the Lord Jagannath. I think this time we have taken up a very important and a common topic, vaginal hysterectomy. Previous 9 episodes we have dealt with many other topics. Believe me, vaginal hysterectomy is close to my heart. I think as a teacher for last 38 years, teaching is my passion, compassion is my treatment is my compassion, and surgery, I am a little deficient in surgery in regards to the other specialized surgeons, because I'm a jack of all trades, master of none. Because they are master of one particular subject, but as a teacher, I cannot avoid anything. And that's why, although I love vaginal hysterectomy, I do all varieties of endoscopic, exoscopic, every varieties I do it. Whether good or bad, you must judge it. But vaginal hysterectomy, when it comes, I think it's a special for me because I have done a lot of strain in acquiring the techniques, and I have done many mistakes than many other people regarding this particular aspect, and this is very alluring to me, and therefore I teach all my students regarding the vaginal hysterectomy. I remember when in my college, my postgraduate does usually start with the non-descent vaginal hysterectomy from the beginning. They usually, I have interacted with other colleagues of mine. They told that, yes, how is that? This is a pinnacle of surgery and you are giving. I think that's a blessing and all that. And I'm proud that my postgraduates can do better, much better vaginal hysterectomy in non-descent state of uterus, maybe large, maybe small, maybe complex, maybe adjacents and all that. They are now experts, more experts than me. They have excelled me. I'm proud of them. So therefore, today I will deal with this vaginal hysterectomy tips and tricks. And this is the flow of events which I want to just find out. Evolution of hysterectomy. Let us discuss something about evolution of hysterectomy and what are the different types of changing trends in the type of hysterectomy over years, changing techniques, as because the tools are changing and techniques also are changing, skills is different, and therefore we are learning the different skills. And then we will focus more attention on vaginal hysterectomy, and that too, how to simplify the techniques. That's the main purpose of this skill transfer. And last I want to have, because this was a confusion, because many times my students ask whether to remove ovary, whether to keep the ovary. There's a lot of confusion. I want to devote some time to clarify some of the issues on prophylactic oophorectomy. What are the controversies and what are the consensus? Removal of the healthy ovaries during benign conditions of the uterus, removing the hysterectomy. Well, evolution, I must pay homage and salute to the great research, great surgeons of those days who have really thought of this, and we are just following. We can improve. We cannot boast that we are doing much better than them, because they are really a persons of genius where we can salute. We cannot do anything. Ephraim Magwell, who is credited with the abdominal hysterectomy, and therefore this particular case, although the results are very poor in the era where a blood transfusion was not there, in the sepsis knowledge of sepsis was not there at that time, sutures, instrumentation, everything was not there. But this person must be remained, and we should remind them that their contribution. James Merriam Sims. Sims is a well-known name in all fields of gynecology, in devising instruments and the techniques for that, and also in vaginal hysterectomy for that. Howard A. Kelly, a remarkable, gifted surgeon in all varieties, he has a contribution for that. And Charles Clay was the person who has done his first successful abdominal hysterectomy, but unfortunately the patient died. He could report it, but this was the situation. He has sacrificed his life, and particularly a lot of criticism was there with that. And this is a person who ventured for the first hysterectomy for that. And Conrad Langenbach, a surgeon par excellence. I think he is the pioneer of vaginal hysterectomy, and particularly without assistant, without a suture material, he could do hysterectomy alone. And there are instances where there was a bleeding and the gouty assistant fell down. So with the teeth and with the two hands and with the leg, he could have the suture and control the bleeding for that. Great. I think salute to this great person, Conrad Langenbach, for that. Now, today's innovations are tomorrow's history. One can only hope that the surgeon of the 21st century will not judge us too harshly and will realize that we are captives of the time in which we practice. There are many people who say that, yes, we are doing like this, what our teachers are doing that. I think that's wrong. We are captives of nature. One other time, we must give a credit. When in my student days where cautery were not there, my teacher was tying the nuts and controlling the bleeding. I was thinking and taking a lot of time for that. Now the cautery is a boon for us. I think we should not take a credit, but we must salute them that with such difficulty they have contributed to the science and to the surgery for that. But as Howard Quelly is 1912, he's told, it was notably anesthesia which robbed surgery of its horrors, asepsis which robbed it its dangers, and cellular pathology which came as a godsend to enable the operator to discriminate between malignant and non-malignant groups. Now coming to the hysterectomy, the past scenario. Let's think about the past. What is there in the past scenario? No anesthesia, no diagnostic armamentarium, only 2 fingers, 2 eyes, 2 cerebral hemispheres, and no knowledge of asepsis, no knowledge of blood transfusion, lack of instrumentation, no hemostatic measures. Survival is a big question mark for that. But still, surgical will was there rather than surgical skill. So the surgical will has prevailed over the surgical skill, which has given rise to the present improvement in the techniques. Now, the present scenario, what are the advances? The diagnostic armamentarium. We have got a lot of preoperative diagnostic armamentarium. Ultrasound is a boon for us, and high resolution ultrasound, CT, MRI, imaging science has really a boon for us. Endoscopy is a boon for us. Profile of patients, physicians, and places have all changed. The profile of patients have changed, physicians have changed, the places has also changed for that. There is improved anesthesia. There is a lot of improvement, not only in the not only in the relaxants, but also in the monitoring process. There is a lot of improvement in the anesthesia, and the skill of anesthetist has also been increased to that. Blood transfusion facility, knowledge of asepsis, knowledge of surgical anatomy and reproductive physiology, equipments and gadgets. Where the gadget-oriented surgery, we depend on the gadgets, the equipments and gadgets are there. Surgical skill has improved, and computer and electronic era, bioengineering has aided to the improvement in the surgical techniques and changing techniques for that. And technological innovations has become a boon, not only in the diagnosis and preoperative evaluation, but during the process of surgery. This has played a very great role in that. So valid reasons to operate. When we are doing a hysterectomy, we should think, ask yourself whether I'm doing this to save life, to relieve suffering, to correct significant anatomical abnormality, and to allow for a creation of a life. I think these are all valid reasons to operate any surgery you find out for that. Now, these are the hard facts regarding hysterectomy. Hysterectomy is the most common operation performed by gynecologists as well as surgeons. I must say again, there are a lot of gynecologists whose husbands are surgeons. They dominate. The gynecologists bring the patient, the surgeons operate. This hysterectomy, cesarean, everything for that. Because I now tell that during this discussion, I must emphasize that every female gynecologist should warn the husbands that there should be a standby. Below umbilicus, there should be a standby. If there is a difficulty, surgical problem, you come. Otherwise, you yourself limit to your above umbilicus. Don't come encroach our field for that. Second most common major surgical procedure in females next to cesarean section. As far as statistics goes, in the United States of America, there is a valid statistics of 6 lakhs hysterectomies per year in the United States. 30.4 per 10,000 women in the UK undergo hysterectomy. 1 of 3 deprived of uterus by 60 in United States of America. And when it comes to Indian statistics, it is as usual. We don't have a documentation and all that. And on indicated surgery, there was a survey recently. There are 3 mainly on indicated interventions, surgical interventions or medical interventions. In surgical interventions, the number 1 intervention is a cardiac surgery, is the first. Second intervention is the joint replacement. Third, we have taken up third. Hysterectomy is the third. Now, hysterectomy has the rank between 1 to 3, and therefore one should ask, introspect, whether you are doing a right thing or a wrong thing, and whether it is indicated or not. So, basic concept of any surgical procedure, selecting the right patient for operation. You bring indications must be genuine. Selecting the right operation for the patient. If there are 2-3 modalities of surgery, suppose in this case we have got 3-4 modalities of surgery, we should find out which surgery is best for the particular patient. Then third is acquiring a good skill and technique, performing the operation correctly. If these 3 are met, fourth you forget, ignore post-op care. I always say the most important post-operative care is a good piece of surgery. I think if you do it and forget it, I think this is the very important hours of surgery which you devote more time and forget about the patient, rather than I believe that most of the post-operative complications are traced back to the intraoperative events. So apart from it, when we come to the pelvic surgery, knowledge and understanding of physiology of reproductive organs, pathology and clinical manifestations of pelvic disease, and dynamics of psychosocial and sexual development. This has to be done. It is not only the dissection which is important, the decision is also important for that. As a surgeon, you must be expert in decision and dissection rather than only dissection, which is a craftsmanship job. Now, when we come to the status of hysterectomy, the key issues, what are the different key issues? Status of uterus to be removed. Number 1, you must find out what are the status of uterus to be removed indications. Status of surgeon, status of route of removal, status of changing trends in techniques. I think these are important in relation to the hysterectomy. When we come to the status of uterus to be removed, there was a saying that the sole purpose of uterus is what? Procreation and creation of diseases. So once procreation is over, why to wait for creation of diseases? You remove it. So it is a terroristic approach. So try to save the uterus as far as possible rather than remove the uterus unless it's very important indicated for that. Status of uterus to be removed. These are indications. Majority, we find abnormal uterine bleeding, adenomyosis or endometriosis, fibroid. These are the majority of the cases, and benign, we removed it, accepting the malignancy. The uterine pathology, these are uterine pathology which is mainly accountable for removal of the. But at the same time, if you find a fibroid, I think all fibroid do not require a removal. I think these has to be symptoms and all that. There are many criteria which I have already repeatedly told where you say no to surgery for that. Cervical pathology, when the unhealthy cervix, many people see the report, squamous metaplasia, CIN1, hysterectomy. I think these are all unindicated cases. But definitely cervical pathology is one of the factors when we find. Adnexal pathology, when there is an adnexal pathology, you remove the uterus. In our time, I think there was a saying that in postmenopausal, when you find a benign cyst also, you do a hysterectomy with bilateral salpingo-oophorectomy. Now, the gadgets are available. You can find whether it's a benign or a malignant in a preoperative screening, and therefore organ preservation has to be done. Pelvic floor pathology. In a prolapse, what happens? Pelvic floor is defective, but the innocent uterus is being removed because the repair is much better for that. You analyze how the innocent uterus is being removed. Obstetric pathology, unless indicated, hysterectomy, in obstetric hysterectomy, we know better when there is a real indication for that, you remove that. Disease of adjacent organs. When there is a cancer rectum, the surgeon tells that if it is a female patient, cancer rectum, you do a hysterectomy, I will do everything for that. So I think these are all additional indicators whether the innocent uterus is being sacrificed. Sterilization method, accepting in United States of America, we do not accept as a method of hysterectomy, as a method of sterilization. We don't. CPP, another chronic pelvic pain. It could be urinary, it could be surgical, it could be psychogenic, it could be anything. But if there is a pain, lower abdomen, remove it. I think CPP is a wrong thing, and one should introspect when not to operate for that. And in many cases, no pathology. Patient is having menorrhagia or heavy menstrual bleeding for 3 months, and without evaluation, they remove it. If I ask, why are you removing this? They say that I will not remove, she will remove it. I think this is an indication where this is absolutely an invalid indication for hysterectomy. So the sole status of uterus has to be removed. To be removed has to be very well screened whether it's necessary or not. Indications are genuine or not. The ease with which the average hysterectomy may be done has proven both a blessing and a cost to humankind. There is no doubt that a hysterectomy done with the proper indications may restore a woman to health and even save her life. However, in the practice of gynecology, one has ample opportunity to observe countless women who have been advised to have hysterectomies without proper indications. I'm inclined to believe that the greatest single factor in promoting unnecessary hysterectomies is lack of understanding of gynecological pathology. The greatest need today among those who are performing pelvic surgery is a better knowledge of gynecological pathology. I think Tillind has correctly said this, and this should be a message to all gynecological surgeons. Now, status of surgeon. I've already told gynecologists versus general surgeons. I think it's a prerogative, adequate knowledge in surgical anatomy, and more than adequate knowledge in pathophysiology. So dissection and decision is important, which a gynecologist can do much better than a general surgeon for that. Surgical skill, commitment, and expertise, set up gadgets and team are important. Ethical, moral, rational, human touch should be there along with the surgery. Now, coming to the again aspect which is very, very important, decision about the route of removal, status of the route, that has been long since debated, and there is no question of debate is already end. I think the consensus is there. Only thing is that the rationality and introspection of the surgeon should be there. It's not the mood of the surgeon, the need of the patient is important for that. So the status of route, vaginal hysterectomy, abdominal hysterectomy, laparoscopic hysterectomy. These are the 3 routes which is available now. And I remember one of my anesthesia professor told that, well, I will ask one question. I have seen you removing the uterus by vaginal route. I have seen you removing the uterus by abdominal route. I have seen you removing the uterus by laparoscopic route. I'm waiting for the time when you can remove by other routes like rectal route, oral route, or something like that. I say, forget about this rectal and oral. Maybe that I pray God to give the gynecologist some of the blessings so that you enchant a mantra and uterus is out. I think no surgery, no cutting, no dissection, no sealing, everything is possible for that also. I'm praying God that the God should give the gynecologist this special mantra for hysterectomy and enchant a mantra without everything will be all right for that. That's impossible. That's really a fantasy. Maybe that a fantasy is a beginning of innovation for that. I dream in my lifetime I cannot have it. Maybe that in future my young students can have it. Now coming to the history again, evolution. First, vaginal hysterectomy is the earliest, 1813. First abdominal hysterectomy is 1863. First laparoscopic hysterectomy in 1989. But now you change, is the situation, the youngsters, the young gynecologists are more inclined for the laparoscopic hysterectomy. Any uterus, irrespective of the size, the difficulty, everything, one single procedure is a TLH procedure. I always tell they are not endoscopists, they are TLH specialists for that also. Gynecologist should be an gynecological endoscopist, not limited to a TLH specialist for that. Because when your only tool is a hammer, every problem will look like a nail. I think if you have one gadget available, everything you do with that gadget. That's not science. That's a dogma. There's no dogma in science. Now coming to the abdominal hysterectomy, we divide into these three. The vaginal hysterectomy and laparoscopy are both aimed to reduce the incidence of abdominal hysterectomy. That is justified for that, and that is basically possible. And because we are in an era of minimal invasion, abdominal hysterectomy should come down, and it should be done by as possible either by laparoscopy or minimal invasive or by vaginal hysterectomy for that also. But till today, I can say they don't have a conviction that these are the two methods and abdominal hysterectomy has gone to graveyard. It is not gone to graveyard. Still, there are some situations where you have to do it. And more than 80% performed in UK and USA, technically easier. Excess of visualization of abdomen and pelvis is there. Enlarged uterus, adnexal pathology, previous pelvic surgery, pelvic pain. These are some of the indications for that. But in terms of gadgets, in terms of laparoscopy, in terms of vaginal hysterectomy, I think now it is for convention and practice that majority of these abdominal hysterectomy have done. But now in the present era when everybody can do all procedures, I say that gynecologists should always have to know vaginal hysterectomy, laparoscopic hysterectomy, and abdominal hysterectomy, and individualize the patient wherever is justified. There is a place, but there is a limited place now. Certainly, there is a drastic decline in the process, but still there is a place. I cannot say no in that, particularly in my experience also. Till today also, I do abdominal hysterectomy as and when required for that. Vaginal hysterectomy, what are the advantages? Oldest recorded in history, familiar with the gynecologist, reduced mortality and morbidity, obese, elderly, and high-risk subjects. It's preferable because it can be done with the regional anesthesia, and particularly in special circumstances like this ventral hernia repair, obesity, elderly. This is all minimal invasive surgery. Rapid recovery, shorter hospital stay, minimal blood loss, minimal instruments, minimal complications are there. What are the disadvantages? No glamour, no money. If you do a laparoscopic hysterectomy, you get 10 times the surgeon fees for that, because no glamour is there. Nobody can see that. It's you and your assistant will only see what is there inside. But patient's comfort after hours of surgery can be remarkable for that, because surgery of minutes rather than hours. It takes hardly 15 minutes to do a simple hysterectomy vaginally, and it requires at least 2 hours to do a TLH for that. Need for good anesthesia, light and assistant is necessary for that. Difficult to learn, but when you learn it, it's easier to practice. Challenging situations, once you do it, you can do from simple to more complex variety. Challenging situations, need for meticulous surgical skill and on. There is no complacency. I think this is important. No blind procedure and no complacency in surgery for that also. And cannot be a never blind. Those who say that it's a blind procedure, they should not attempt vaginal surgery for that. Laparoscopic hysterectomy, the scope is now increasing, scope of scope is increasing. Definition, the Jones classification, merits over abdominal and vaginal hysterectomy. There are some merits over the abdominal and vaginal hysterectomy also. The types, the technical aspects, the advantages versus disadvantages, complication, future. I think this is in this particular session, I will focus more on the vaginal hysterectomy. Subsequently, we can discuss on laparoscopic hysterectomy in more greater detail. But remember one thing, when Hari Rich, who has done the first laparoscopic hysterectomy, he was asked whether to choose laparoscopic hysterectomy or vaginal hysterectomy. He has commented that when vaginal hysterectomy is feasible, laparoscopy is to be condemned, and that is the procedure for that. So 80 to 90% of the so-called hysterectomy can be converted by the vaginal route, and the rest there is an indication for laparoscopy. Laparoscopy is a boon for vaginal surgeons, because the laparoscopy, presence of laparoscopy gives a more of confidence on the vaginal surgeons. If there is a difficulty, I will put a scope and in between convert it. And second important, more difficult cases, to make difficult hysterectomy, vaginal hysterectomy easier, laparoscopy can be a method for that also. So we cannot say that this is superior, this is inferior. This is a complementary procedure. Whenever it's indicated, we do it. Otherwise, same thing, no dogma. Many vaginal surgeons, they say, all cases I will do vaginally. I think that's wrong also. There should not be any dogma for that. Other key issues, subtotal versus total. Supracervical. There are a lot of about 3 decades before, there are a lot of literature about supracervical hysterectomy. Supracervical hysterectomy, because keeping the cervix intact and rest removed. It can be technically easier, but it should not be restricted to all cases. There is majority of the cases, not because of technical difficulty you do it, I don't agree with that. But in special situations, you can do that. Laparoscopic assisted vaginal hysterectomy versus TLH. Now, TLH has become very, very popular. People are forgetting the laparoscopic assisted vaginal. They say that laparoscopic assisted vaginal hysterectomy, LAVH, is a little inferior procedure than the TLH. Believe me, the procedure why LAVH has been launched. You find out LAVH, laparoscopic assisted vaginal hysterectomy. You see the anatomy, even for a complex or a simple cases, it is easier to reach optical uterine by vaginal route, and it is easier to reach optical uterine by laparoscopic route from above. So from above, the problem starts after uterine, and the problem starts in vaginal again after uterine, and therefore you combine the procedure, and that is the concept of laparoscopic assisted vaginal hysterectomy. You just remove the adhesions and all that, clear it and all that, and then do it from below for that. But now TLH is also an acceptable procedure but it should not be employed for all cases for that. Ovarian conservation versus removal, I will devote some time. Clamp versus clampless. Suture versus sutureless. Nowadays, the sutureless procedure, the technological advances of the bipolar, cell-safe technique or vessel sealing technique is a boon. Staged versus joint procedure. We can do a combined surgery, vaginal hysterectomy and lap call, which is a combined procedure. The surgeon does the laparoscopic cholecystectomy. You do the vaginal hysterectomy. Completion versus conversion. There should not be ego. And if there is any difficulty, during the process, you convert it. There is not a problem. You don't say that it's a undignified thing to convert it also. For the sake of the patient, for the benefit of the patient, for the safety of the patient, I think there is no ego. Now, present scenario, the advances of vaginal hysterectomy, diagnostic armamentarium has increased, profile of patients, physicians and places have increased, improved anesthesia, blood transfusion, knowledge of asepsis, knowledge of surgical anatomy, equipments, gadgets, technological, all these, as I have already told. But glamour, fortune and commerce still evolves around hysterectomy. Complications are likely, but more often with simple cases, not with difficult cases. When you are cautious, when you think about it, preoperative planning, you can make it more difficult cases more simple. But when you are overconfident, a very simple cases, you land in problem. Majority of the complications occur where you are overconfident. Be confident, but don't be overconfident. Will to perform and skill to acquire is the theme, and no dogma in science. And again, I will emphasize, need of the patient is more important than mood of the surgeon, because the safety is first. You don't do any harm for that. Changing concept. What are the changing concept? From abdominal to laparoscopy to vaginal. From big hole surgery to keyhole surgery to no hole surgery. Big hole laparotomy, keyhole is a laparoscopic surgery, and vaginal hysterectomy is a no hole surgery. From invasive is abdominal hysterectomy, minimal invasive is a laparoscopic hysterectomy, and non-invasive surgery is vaginal hysterectomy for that. From big scar is abdominal hysterectomy, to small scar laparoscopic hysterectomy, to scarless surgery is vaginal hysterectomy for that. So no dogma in science. There is a place of all three, but don't have a dogma in science. The laparoscopy should not say that all cases I will do with laparoscopy. Vaginal surgeons cannot say that all cases I will do with vaginal. There should not be any dogma. There are reasons for laparoscopic hysterectomy, indications for that, and there are indications of vaginal hysterectomy. But the fact remains that 80 to 90% of the hysterectomy can be done by vaginal route. Only the rare cases where there is adhesions, where there is indication, when there is a pain, when there is an endometriosis, these are the cases where laparoscopy can help in a better way. So, vaginal hysterectomy, ladies and gentlemen, is a dying art or a growing science. You have to analyze, you have to introspect for that. Now, very important terminology, NDVH has been imprinted on the gynecologist, non-descent vaginal hysterectomy. Till today also, I don't know, we are a part of that, propagating the NDVH word. Now I think there should be vaginal hysterectomy. If you consider these these two terms. Vaginal hysterectomy is synonymous with non-descent. When we say vaginal hysterectomy, it implies that it is non-descent. When we say vaginal hysterectomy with pelvic floor repair, it implies that it is a descent uterus for that. But whatever it may be, you can use the NDVH or if you can use the vaginal hysterectomy. That means it implies that there is no pelvic relaxation. And when there is a VH with PFR, you can say that yes, it's a pelvic floor repair is done. So the planning, very important, vaginal hysterectomy, the planning, pre-op feasibility assessment and planning. This is important. Pre-op feasibility has to be analyzed. Assessment is important. Number one, again, I emphasize, what are the indications? Symptomatology. You analyze the symptomatology, patient preference. If the main symptoms is pain abdomen, unexplained pain abdomen, even you find that the mobile uterus, I will not do a vaginal hysterectomy. I will put a laparoscopy to see what is the cause of pain abdomen. Symptomatology. If there is a simple dysmenorrhea, sonographic evidence of adenomyosis, mobile uterus, I will go for vaginal. But otherwise, if there is unexplained pain abdomen, pain is a predominant symptom, I think this is important. Symptomatology. Clinical assessment, you have to assess clinically by doing a pelvic examination. You find out the size of the uterus, the mobility, the lack of space, the lateral vaginal space, the access, whether it can be done or not. I think these are all important. With the growth of technological innovations, with the growth of scopy and scanning, we are losing our clinical sense. I always say that there should be a blend with tech and touch. The tech and touch blend should be there in the present situation further. The role of sonography is immense because we can plan the role of sonography. You can do whether the pathology is there, whether it's a myoma or an adenomyoma, because it's you just doing a hysterectomy in a myoma and adenomyoma are completely different thing. Then we can know the planning of the uterus volume. What is the volume of the uterus rather than the size of the uterus for that. Whether in the transverse plane it is more or in the enteral cephalocaudal pole it is more for that. That's important. Whether there's some adnexal pathology which is there or not. So role of sonography is immense for that. Need of laparoscopy, as I've already told, when there is a symptoms of pain, you put a laparoscopy. If there is nothing, then don't do a laparoscopy. You just laparoscopic as a, this is stage 0 laparoscopy, previously Johnson had told. But this is a sonography, laparoscopic as guided or in diagnostic. You do it and everything is normal, then convert it into in the vaginal. Anesthesia, OT setup, and assistant are important. Role of EUA, examination and anesthesia. If you have done an OPD without anesthesia, the findings are really different from anesthesia and examination and anesthesia. You can assess properly the size, the mobility, the fixity, and the pathology for that. And ultimately, everything boils down to the skill. Skill development is very, very important for that. So the surgical techniques, when I say that now we come to the surgical techniques, what are the different surgical techniques in vaginal hysterectomy? I will share my own videos little later, but let us say hemostasis. Important is hemostasis. It should not be a bloody surgery for that. And a lot of procedures are there for hemostasis and the infiltration of the dilute adrenaline or vasopressin solution. This is important so that you can go to the correct plane and cleavage without any undue bleeding for that. Simplification, whatever steps you do it, you must be simplify procedure, and simplification of the steps has to be done for e.g. for the completion of the procedure, because the teaching will be more, people will be really inclined if they see a simple surgery, simplification of the steps without any complication. And recognizing problem and rational management, immediately identify the problem and identify the surgical limits and patient safety. You must know what is your limit for that also. And if this has to be taken, you can do more and more procedures by vaginal route, more and more difficult procedures, difficult vaginal hysterectomy by that also. Now, hemostasis, hemostatic agents is important. As I have already told, we infiltrate. Some people do a aquadissection, too much of infusion, about 200 ml pericervical regions. That's also a method for that. But some other people use only in anterior, only the side line of incision. They just infuse it laterally, 3 and 9 o'clock position and 12 o'clock position. And hemostatic agents, about the 30, 40 to 50 ml of this dilute vasopressin or dilute adrenaline is enough for that. Tissue planes is important. You dissect correct through the tissue planes. See, if you go to the correct tissue planes, bleeding will be less. So that's important. The correct tissue planes to be identified. And of course, electrosurgical device is a boon for us. And bipolar is really a boon rather than the monopolar for that and others. Now, the steps are, first is in vaginal hysterectomy, access to the pouch A and P. I've already told about the pre-op assessment and EUA and feasibility of that. And then you start the procedure, access to the pouch A and P, A pouch and P pouch. I think this was there when we started. You open the A pouch, open the P pouch, then things will be easy for that. But in some challenging situations when there is an adhesion or when there is a large uterus, it's difficult to enter. Don't try to attempt A and P pouch and then proceed the procedure. You just closer to the uterus. You go closer to the uterus, either suture it or bipolar sealing system. Go closer, both anterior and posterior, because there are two dangers: anteriorly the bladder and posteriorly the rectum, laterally the ureter. So these are the three main enemies of first and vaginal hysterectomy. So closer to the uterus will save everything for that also. So maybe whatever procedure you do it, abdominally, vaginally, laparoscopy, always this is make it a principle, closer to the uterus. And in all, even if the rectouterine, the POD is unexpected. There are some unexpected situations. You find that everything is normal, and when you find that there is an endometriosis, undiagnosed endometriosis, and there, don't be scared about it. You go closer to the uterus. Ultimately, a time will come when everything will be there. You can see these adhesions have gone up, and you can go clearly in a safety line for that. Suture versus suture. Sutureless is a boon for us. Bipolar vessel system is a boon nowadays. But suture, one can do it also. Our experience also, we do it. But the more complex procedures can be better tackled with the sutureless procedure. Large uterus, you debulk it. Debulking the uterus, limiting the size, and through the vagina, it can come out for that. Bigger uterus can be debulking, and either by bisection or by myomectomy or by coring, you can reduce the size of the uterus so that you can get a more space to go for the lateral part and ligation or suturing for that. Adequate tissue respect, whatever surgery you do, adequate tissue respect should be there, and hemostasis is a paramount importance. Don't do in a bloody field. Always hemostasis. I always say hemostasis to the surgeon, oxygen support to the anesthetist. If these two are targeted, there won't be any intraoperative calamity. Remember this. If you take care of these two, intraoperative calamity will not be there. So paving the way for difficult vaginal. When we find a difficult vaginal hysterectomy, paving the way, it needs a conviction, it needs an inclination, it needs a perseverance and indulgence for that. Now, there are some blocks, mental block of an gynecologist. There are some problem. In some cases, descent. If there is no descent, how can I do it? It's a mental block. If there is no excess, I can't find it. Excess, how can I do it? Size is big, how can I do it? There are adhesions, how can I do it? Everything has got a limit and a solution for that. And it's a mental block of gynecologists has to be need to be banished. I say that there is a more of mental adhesion than the pelvic adhesion. The size can be done, even if large size can be dealt with by morcellation, by debulking. Access, you can increase the access by many of the procedures of the current technology. We can have an access for that also. And bipolar is a very good method. Energy sources, if there is a less access for suturing, I think bipolar is a very good, and in a less accessible area, you can use this procedure. And descent, once you go for the uterosacral and McEnroe's, I think descent will be more easier for that. Now the key issues: morbidity from days to hours, operative time from hours to minutes, setup from sophisticated setup to rural setup, we can do it. Training, difficult or easy? It's easy. And complications, too many or too little? It's too little rather than this. So if at all you diagnose yourself as a gynecologist, the signature of a gynecologist is vaginal hysterectomy. Do you want to diagnose yourself as a gynecologist? Define ends here. There's no debate for that. So these are barriers of vaginal hysterectomy. Scar, if there is a scar, cesarean section, is it a contraindication? Size is more, is it a contraindication? I think more important is skill. Is it? I think if we improve the skill, everything will vanish for that. Now, igniting change, I will say little time, because sutureless hysterectomy has become a routine practice of all gynecologists nowadays. It's a simple procedure for a complex pathology. It's a patient-friendly. It is a surgeon-friendly also. Because I say that if you are using less of this, you can use in the case of HIV, HbA patient, because you are secured for that. Minimal and minimal invasive surgery, more difficult cases you can do it for that. And we use the varieties of this suture. Basic principle is the bipolar technique, vessel sealing system. Yesterday's contraindications are today's indications. The basic surgical philosophy is which vessel has to be coagulated, which vessel has to be sutured. The earlier philosophy was there that any vessel which has a name to be sutured, any vessel which doesn't have a name to be coagulated. So uterine artery has a name, it should be sutured. But now yesterday's contraindications are today's indication. When the sealing zone is there, when a vessel sealing system has devised, it can seal 7 millimeter vessels. I think there is no harm, no need of suturing the uterine. It can be coagulated. It can be very well tackled with the current vessel sealing system for that. And these are some of the automatic bipolar mode auto sensing devices there. You just coagulate and find out, and then you do the procedure for that. So these are all the Martin, the RB, the other Indian system is also very important. PB, Alan, there are various Indian system which is very used, and reusable and durable instruments are there also. And these are all bipolar vessel sealing system. For open surgery also you can use it. And technical aspects and design, these are ceramic pins, and outside is insulated so that the current doesn't spread to the outside and doesn't touch the intestines or other things for that. So advantages of this system: effective sealing of tissue bundles or vessels by melting the collagen present in the vessel walls without any previous dissection and detailed exposure. So the sealing zone is increased for that. No extraneous material, less electrode incrustation. It is a time-saving system as compared to the other thing. So the scope of sutureless hysterectomy is increased from benign to malignant, from abdominal to vaginal, from simple to difficult pelvic pathology, from personal variable technique to uniform standardized procedure. A surgeon is expert in suturing. I think with this, a novice and expert are all same. The procedure, you just clamp it, the size and apply, put the pedal. I think the machine will do it and all that. So uniform standardized procedure. So why sutureless? Demerits of sutures: inadvertent pricks and hematoma, slippage, pain, infection, adhesion, foreign body reaction, tissue compatibility, difficult in suturing in some critical cases, critical areas, like infundibulopelvic pelvic when you are removing it, like a difficult cases where the access is less for that. It has a least lateral spread, reduced thermal damage, vessel sealing, plasma kinetic, auto sensing, auto stop mechanism, least smoke, least tissue damage, rapidity of the procedure, reduced cost of the suture materials, reduced post-op pain and morbidity, reduced secondary hemorrhage, because the smaller vessels are secured for that. There is no, I think, the additional continuous oozing and collection of the material, collection of hematoma inside for that, psychologically gratifying to patient. Now, the next aspect which I will just tell, oophorectomy during hysterectomy. This was absolutely, many students ask me whether to remove the ovary or not during the hysterectomy. There are a lot of controversies, but consensus is really achieving for that now. Oophorectomy, these are facts and fictions. Ovaries, after long years of dedicated service, is not able to retire gracefully, and rather, instead of retiring, it is irritated and transmits the irritation to various systems, and you see the manifestations of the postmenopausal symptoms. And when you give a forceful retirement by doing a surgery, I think how you imagine how the ovaries will be, how the hormones will be affected, and the transmission will be there, the irritation will be there. That discrimination in terms of dignity and respect exists between male and female gonads. How many male gonads are being removed, but female gonads are being sacrificed? There is a masculine dominance over the female partner for that. That female gynec surgeons chop up ovaries more frequently than their male counterpart. Please excuse me, the female gynecologist, but I have seen female gynecological surgeons chop off ovaries more frequently than their male counterpart. Male surgeons, gynecologists have a respect to the female gonads. That ovarian cancer phobia is inherent among gynec surgeons. They are always, the cancer phobia is there. If you leave it, it may come down as a cancer. That it is very easy to put clamps lateral to ovaries during abdominal hysterectomy and laparoscopic hysterectomy, but put clamps medial to ovaries during vaginal hysterectomy. It is easier. So that's why, for a convenience, you do it. That unilateral oophorectomy reduces the future cancer risk by 50%. It's a gimmick. It's not. It's a myth. It's not a reality for them. So ask some questions. I have just designated some of the questions. After, think about these questions and you get the answer for that. First question: at what age does the ovary ceases to function? One should know. Increase in normal age of menopause from 4th decade to 5th decade. Waning ovarian secretion, hormonal secretion during perimenopause. 23% of women show histologic evidence of ovulation after the age of 50 years. Majority of hysterectomy for benign disorders are premenopausal, and 3.8% are postmenopausal. Women with bilateral oophorectomy between 40 to 45 years may lose 10 or more years of normal ovarian function. So you must know that by removing the ovaries, you are depriving for a decade of functions, ovarian hormones. Second, do preserved ovaries continue to function normally after hysterectomy? You have done a hysterectomy, preserve the ovary, but whether it will continue. Target organ relationship. Even if you say that you remove the ovary, you keep the ovary, remove the uterus, we find immediately in some cases the hormonal withdrawal symptoms like a flushing spells. This could be a temporary effect for that. And ovarian failure occurred up to 4 years earlier after hysterectomy compared with non-hysterectomized control group. 11.6% of women who underwent hysterectomy had ovarian failure at the end of 4 years. Menopause doesn't increase in frequency following hysterectomy, but transient appearance of vasomotor occur in approximately 40%. This is a transient phenomenon. And transient reduction of blood flow and steroidogenesis after simple hysterectomy has been explained by this. Can operative technique affect ovarian function? Knowledge of blood supply, twisting or stretching of infundibulopelvic, clamps closer to the uterus, removal of the tube, peritoneation and persisting suture around adnexa, coagulation versus suturing. Can operative technique affect ovarian function? I think these you ask yourself, and these are all to be answered for that. Are there significant health hazards when normal ovaries are removed from premenopause? If you remove an ovary from premenopausal, all cases, what are the what are the significant health hazards? Effect of sudden decline of estrogen, progesterone, and is absolutely true. Significant decrease of testosterone and its effect, long-term metabolic effects, osteoporosis, CAD, CVA, diabetes, metabolic symptoms, and psychological effect for that. So there are significant health hazards when normal ovaries are removed premenopausally. Are there significant health hazards when ovaries are preserved in premenopausal women? What are the premenopausal? If the ovaries you keep it, what is the problem? There could be non-neoplastic problems. There could be neoplastic problems. In non-neoplastic problems, the residual ovarian syndrome, adnexal masses, severe pain, dyspnea, generalized pelvic discomfort. This is noticed. And in many situations also, we come across residual ovarian syndrome benign, where subsequently laparoscopic access and removal was possible. Benign cyst formation, even hydrosalpinx, then the pseudocyst formation. These are all could be there if it's there. And cancer, when we come to the cancer, the incidence is baffling. 0.1% to 18% is a very, very baffling incidence from different centers for that. But believe me to say, you have to require to do a 1 lakh hysterectomy to save 1 ovarian cancer. And therefore, think about the quality of life and think about preservation of ovaries as far as possible for them. How effective is hormone? We say that we remove the ovary and hormone replacement is there. Pharmacological versus physiological, there is a hell of a difference. Merits versus risk, short-term versus long-term, choice of drugs, long-term compliance and affordability. Future research is awaited for that. And how rational is age? Many people say age is 45, remove it. So this was there. This UK, there was a literature where discuss oophorectomy at 40, recommend removal after 45. But this is arbitrary. Believe me, age is arbitrary rather than rationality in cutoff limit in premenopausal. We say that age is cutoff limit in premenopausal is purely arbitrary. Consensus in postmenopausal, you can do it, you can remove it, but premenopausal is absolutely arbitrary. Associated factor, you must find out what are the associated factors for that. And therefore, the consensus, organ preservation and conservatism, essential theme of the millennium. Postmenopausal and risk factor for ovarian malignancy, you remove it, radicalistic approach. Age is only arbitrary, not rational. Adopting proper surgical techniques is important for vessel, for impairing of the vessels, for affecting the ovarian functions. You must Unilateral oophorectomy, only a psychological bias. You are not reducing incidence of ovarian malignancy by 50%. HRT is mandatory when you remove, lack of evidence-based statistics for that. And this is the message which I must say, that all gynecologists should ask before hysterectomy whether there is a history of family history of ovarian malignancy, breast malignancy, colon malignancy. If you ask particularly one question, that if there is a strong family history of ovarian malignancy, you remove the ovary irrespective of the age. Even if at the age of 35 you are doing a surgery for benign conditions, you remove the ovarian malignancy, family history of this. BRCA positive, there's an indication. If you do a BRCA positive, you remove the ovaries for that. And there are some really other indications where it is relative, repeated surgery. A patient, there are a lot of 3-4 times surgeries be there, and this time again surgery is there, repeated surgery. You may think that this patient is prone for surgery, you may develop another surgery, you do. I've seen peri-ovarian and adnexal adhesion. It is a normal, it's not a pathological ovary, but peri-ovarian and adnexal adhesions are there. There you have to remove the ovary. Otherwise, these are the cases where we find the pseudocyst formation, the residual ovarian syndrome, the persistence of the pain will be there in that. And of course, nowadays, when we know that the ovarian malignancy is not from the ovary and from the salpingectomy, from the salpings, from the lateral part of the salpings, the majority of the advanced serous cyst adenocarcinoma is being obtained by this. The tube is defective. Now it's a routine practice of almost all gynecologists to remove the tube. And the question comes, by removing the tube, whether the blood supply to the ovary is impaired or not. I think this is another supply for that also. And therefore, salpingectomy could be advisable. There are late researches, there are a lot of reports where salpingectomy, 70 to 80% of malignancy can be prevented, residual if you do a bilateral salpingectomy for that. So knowledge is the process of piling of facts. Wisdom lies in their simplification, and that should be the answer. A new scientific truth doesn't come by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it. I always remember Francis Bacon statement, read not to contradict and confute, not to believe and take it for granted, not to find and discourse, but to weigh and consider. And all these episodes of surgical skill transfer and solving clinical dilemmas, you are the wisest person. You get information from all varieties, but to weigh and consider. And if you weigh and consider, that will be a right thing to do it, and you deliver the goods for that. Now, this is a case, this is a video which I saw. Can you see there is a scar, and I'm pulling the cervix, the scar dimples. I'm pulling the cervix, the scar dimples. So pre-op assessment here is not, don't go dogma for the vaginal hysterectomy. You put a laparoscopy, you find a complete ventral fixation. I think the whole uterus is fixed to the scar. So these are the cases. Even with the clinical examination, you just find out, convert it into a laparoscopy. Don't have a dogma that I'm a vaginal surgeon, I will do that. So this is the first thing I will say no to vaginal hysterectomy wherever is possible, and find out preoperative assessment is most important. You'll find whole of the uterus is, so you can clearly dissect it by laparoscopy and remove it and do a laparoscopic hysterectomy after this procedure. And then things becomes much more easier for that. You can see the ventrification clearly. The whole anterior segment is fixed to the abdominal wall, anterior abdominal wall. Be cautious about the bladder and just ligate, free it, visualize you do it, and then things become very easy. So many of the cases, there are techniques of attempting ventrification in a vaginal hysterectomy also, but that's a very special cases, very extraordinary skill is required to do that by posterior approach for that. So before going to these particular techniques for that, I will just highlight some of the tools. You have seen the gadgets, the too many instruments are there in abdominal. Too many instruments are there, particularly in laparoscopy for that. But when it comes to vaginal hysterectomy, the tools are limited. Just remember that with the 10 instruments, you can do this. 10 instruments with a single tray, this you can give it. And I have customized the instruments by one of the company, Toft company. These are the single-bladed speculum. This is especially variety. You have a lot of sim speculum. I know that sim speculum can solve the purpose, but single-bedded vaginal speculum of a desired width, desired length is important for that also. So therefore, two speculum, 10 instruments. You can see the speculum, the curvature of the speculum and the design of the speculum. All the companies have done it, and you can do with the two, one in the posterior, one in the anterior for that. The third, again, we find is a bulldog clamp. You can catch hold of the cervix and give a traction with this clamp. This clamp can do other removal of the myoma and other places for that. I've just customized it by the tough people that give it with the, for my gynecologist convenience. They like a simple instrument, very cheap instruments is there. This is a myoma screw which was there, used earlier also, but this myoma screw can be very helpful in vaginal hysterectomy. Even in deep-seated myoma, we can put a screw and deliver the myoma, big myoma from the vaginal root for that. It's a very valuable instruments for that. Seizure, a good seizure is necessary. A cutting seizure that cuts, this is important. We do not find a good seizure also in many of the OTs and all that. And this is a seizure. In one pack, I have given these 10 particular instruments and told the tough people are manufacturing this vaginal hysterectomy set for that. This is a very good, this you can use it for a multiple purpose also in all varieties. This is a clamp. It's a very good clamp designed by that. And this is many clamps are slipping. I think you make it a good design clamp where it really grips it. Multiple things, serrations are all there. And this is a clamp. Two clamps are necessary. One is this type of clamp is an ordinary clamp. Another I have designed a different type like sets, series sets clamp. It's not a very long instruments like a series set clamp, but it's just a different type. And this is I will show you how it is beneficial. This you can use it if you are not doing a sutureless. You can use this clamp. You can use it in the upper pedicle. And this is a relatively short instrument. It's not like a series set clamp, but a curvature is so designed that you apply and automatically it goes through the upper pedicle for that. This is one. And the same clamp you can use it for ovarian removal by putting a clamp by you just cut it the round ligament and just go and catch the infundibular pelvic ligament for that. It's a very stout instruments. Two instruments are there. Two clamps are there. Then this is a curved artery forceps. I always prefer a curved artery forceps is much better for suturing in the pelvic surgery for that. And therefore, with the less of space, this curved artery forceps is much better for that. Then we require a suction. This is a suction and a metal suction. Metal suction is important because this serves two purposes, suction and retraction also. So this is important, a very cute instrument, and we do not want many long instruments and a volume. This is a cat's paw, which is important in terms of the myomectomy, in terms of debulking procedure. This is very important for the morcellation procedure, and this is so these 10 instruments are enough. Along with it, only 2 Ellis forceps you needed, nothing else required for that. How many spaces, how much space it will require in your OT, and this is the only thing which, if you are going for more sophisticated tools like a sutureless techniques, you require more something as impossible that you require that. But these 10 instruments can be put it. I have designed and customized into a particularly one chamber, a very small chamber of steel, which is can be autoclavable. And this I have designed particularly for vaginal hysterectomy. So the Taft has designed vaginal hysterectomy set and 10 instruments, and with the design of steel, it's a very good. You can carry it and all that. You can keep it. You can do the autoclaving with that also. So the small holes on the two sides are for autoclaving. You can put it. So deliberately, for the benefit of all the viewers, I'm just demonstrating this particular with this 10, 12 instruments. You can do whole of the procedure for that. So mini instruments, mini surgeon, and mini assistant. You can do a very mega operation for that also, and very complex surgery. You can do it for that. Whole thing can be put it into it, cover it, and you can autoclave it completely for that. And you can have that Caesar, keep it separate also. You can keep it there, whatever. But this is a situation where the autoclaving is there. You just put it and close it, and this is a very useful instrument for vaginal. I thought during vaginal hysterectomy, I've traveled across, done a lot of workshops in different places. In a big hospitals also, you don't find a good speculum. Sim speculum, small variety, you can't get a place for that. So these are some of the instruments. Now, this is an additional thing where the access is difficult. Light source is important. You have a fiber optic light source. This I have designed. There already this type of speculum with the light source is available, but I've just modified this in the two forms. The two angles we have done it that. And here is another light source is there. The original thing is that we have just in the proximal and distal, it is divided into Y, and then this again, this I have devised into a light source with suction. This is available with Tuft also. This is a light source with suction. At the two ends, you can do that. The suction end and here the light is there in the 3 centimeter distal to it, and one end you attach the fiber optic cable, one end you attach the suction machine. So it serves purpose at a deeper plane where the bleeding is there. You suck it so that you know that there is a bleeding in there. These are some of the other instruments. This is a Alan set where we find that small instruments for vaginal hysterectomy and abdominal hysterectomy also it can be used, and it serves the two purpose. It just no need of cutting also. The tip cuts it, and this is a shear. This is a shear. This is called shear. You just hold it, clamp it, and at the distal part, this is laparoscopic shear and open spear. Both are available for that. This is of Martin Marklam, and you see as I've already told, the inside is outside is insulated, blue one, and inside there are active blades, and you applied IQ model where the vessel sealing is absolutely very good. The length is about 3 centimeter and all that. And smaller instruments are available with this also. This is one smaller instrument of the IQ cut IQ is again Martin's a different device for that also. I have some of the modifications with the Martin also with that. And this is an instrument which coagulates and cut it. The cutting is by mechanical. Shear cuts alone. There is no need of cutting. Shear itself has a machine for that cutting for the current. But here this is a thing where you just press it and the cutting is there. You just coagulate it at the end and press it. I have asked them to make the design in the length should be more for that. Now the length is almost around 1.82 centimeters, too small for vaginal hysterectomy, but certainly is very beneficial because the force is much more, the coagulation is very good. You for the uterine and all that. After the clamp, you just press it and automatically the mechanical blade will cut it for that. It's not a auto cut mechanism as we have found in shear. Shear is auto cut, and this is a thing where it cuts it. You can see the blade moving, and this is very important. This can be a multiple purpose in all types of surgery. It can be used also for that, and this is also important for that. So because tools are important, and this sutureless area of sutureless, I think initially started with the biclamp. There are a lot of modifications, and there even with the harmonic also we can do that. This is a machine of Alan, Indian variety, which is a cost effective, and this can use it all composite, unipolar, bipolar, vessel sealer, underwater cautery, everything can be done with that. And Martin also is a very, this is a electrosurgical device, and the Johnson's Ethicon is the harmonic is different, and these are also electrosurgical device of Martin Maxium, a new model which has given it, and all sophisticated things are there. The vessel sealing system is very good for that. It can be used for all purpose, both laparoscopy as well as underwater cautery and other cases. This is harmonic and all that. With the harmonic also, you can do a vaginal hysterectomy. But here, the harmonic blade, unlike the laparoscopic instrument, you cannot use it here because it's too long. Therefore, the harmonic, this is a small hand instruments of harmonic wave. We call it as a wave. And this wave is a small, this we can use it in open as well as the vaginal hysterectomy. So this can be done, but the only thing you see that the current strength, it should be less. If you use that 1 and 3, I think more close to the lower wattage, it takes a little more time. So the sealing capacity, we know that the bipolar sealing is more efficient than the harmonic. But remember, if you're low setting, you do it, harmonic is also quite effective for that also. Now, this is a case of the vaginal hysterectomy, which I'm just showing you that this is another instrument of Martin, which is a cutting instrument also. You just coagulate and just fire it, and the mechanical thing cutter will be there. No need of a Caesar also with that. This also can be used in abdominal as well as vaginal, and this instrument is little curved. It's more suitable for the vaginal hysterectomy for that. It's not a mark clamp. Mark clamp is a different thing, but this is more beneficial as far as time is concerned, as far as the access is concerned. With the least accessible place, we can use this particular instrument. And you can see that after that, how the blanching of the tissue, vessels occur, and how the coagulation is complete for that also. So these are the cases where a size of the uterus of about 8-10 week size uterus. Now the main procedure of delivery of the uterus is posteriorly, always posterior, and the upper clamp, as you have seen, the upper clamp, I have clamped it here. You can coagulate it also by that, but by making a clamp, the advantage is that you reduce the space. You can find more of space after that. You remove the uterus and find more of space, so that after that you don't have to again tie, but again after that you get a lot of space, you coagulate it. And if you want to remove the ovary, you can remove the ovary. If you do not want to remove the ovary, only the tube can be removed for that. But this is a method where from the beginning till end, we are using the vessel sealing device, and it's very good. And suction, we are doing it because it produces little smokes. We are not the suction of the blood, it is suction of the fume is there. And periodically, if we know that there is some rise of temperature here, sprinkling of the normal saline. We're using the sprinkling of the normal saline and smoking the vacuum is more complementary to each other, and that can serve the purpose for that. And if you're removing the ovary in this space, it is very easy. You just put a cuff, I think the gauge piece inside, and so that the bowel are there. This is a real danger, that the bowel should be kept away from that. So this is a method. I have always kept a preservation, a swab in the distal part, and go slow. It's not a blind procedure. You just slowly go and coagulate the pedicle. This is important because the upper pedicle is a thicker and broader pedicle, and the bleeding occurs posteriorly from that unless it is coagulated properly. So either by tying or by coagulation, you can do that. And this is after the end of the procedure. You just hold the angle, and the two angles, you hold it one angle, you start the suturing and closure of the vault. It's the closure of the vault along with the prevention of the vault prolapse. So that's important. So how you fix the lateral angle is important. Either you do a Macal's scaldoplasty, or you can do a simultaneously the two lateral thing for that. Because two lateral things, what I do, I always prefer that we are not doing a circular incision. We are keeping the anterior incision transverse posterior, and the lateral incision, the vaginal wall is fixed to the uterosacral and mecanor. So there is no need of that, and of a circular incision again giving it and then fixing it. So therefore, if the lateral vaginal flap is fixed to the uterosacral and the mecanor, I think this is really a boon that you leave it and all that, but take a little bite from the angle and this is the anterior pouch. You see, after you see it's a blanching. Don't put a blunt dissection. It's a sharp dissection of the. You cut the cervicovesical ligament, and you can go directly for that. I think this is the important thing: the anterior pouch and posterior pouch. You may open, you may not open. It's particularly if it is open, that's all right. But if it doesn't open, don't be bothered about it. Go close to the uterus for that. And remember, after with one stroke, if there is no adhesion, you can see it's open. It's absolutely the peritoneum is seen, and put the speculum inside. You can go through the posterior pouch. Once you go to the posterior pouch again, the main philosophy is there that you should be closer to the uterus for that. And this is a case where we find a pouch and posterior pouch. A pouch, you may not open it, and at that point of time when the uterine came, it automatically opens. Now we do that. I always recommend now. Earlier I was recommending opening the A pouch is mandatory and posterior pouch is mandatory. Now don't think about that. And this is again a Alliance, the machine, Alliance bipolar vessel sealer, where the current can cut it. You just don't use the Caesar for that also. So at the tip, it cuts it and it acts like a sear. And it's very easy because the access can be better in less accessible area. You can do that. And once the uterosacral and Meccan rods is been cut, automatically the descent is more. You can see that everything is gone down. And this is the uterine. You go closer to the uterus. This is important, and you can see the uterine knuckle there. And closer to the uterus is very, very important. You can see the clear. There is no need of skeletonization. Also, I have not cut the anterior pouches. I have not cut the peritoneum. At this point, after uterine, automatically the uterovesical fold of peritoneum will be seen. And on either side, you can see the uterine knuckle and go closer to the uterus, because the lateral spread, we do not know what should be there. We know there could be lateral spread, but that's why we don't go more laterally. But very, very important, you must see that the coagulation is complete. You can see the uterine now, and after the uterine, you can see that yes, the automatically the peritoneum is can be seen, and this speculum can be a bone. You can have a light for that, and excess light. I've used the headlight also, tried with that. That gives more discomfort to the surgeon, and that's why I don't like the light also. With this fiber optic light also, you can do it. With the suction light, you can do it additionally. But I think with the good light source in the posterior part over the head, if you put it with the normal light in the OT, can serve the purpose for that. And this is a thing where after the uterine, you can find clearly the uterine, the uterovesical fold will be automatically open for that also. So that's important. And once it is there, you can find, can you see that automatically the peritoneum is open? You just cut it, and no need of catching it and opening it and all that. Now the peritoneum is open. You can do it. The upper pedicle, you can go after that. The upper pedicle, you can deliver. But the main thing is that after that, the delivery of the uterus is mainly, we find a posteriorly more of space. You deliver the uterus by posteriorly, just keep it and all that. And then you can apply the clamp, or you can apply the Mar clamp for that also, and coagulate for that. Just posteriorly, you just hook it and it will come out for that. And this is the way we do it, the vaginal hysterectomy. You can do it with suture also, but sutureless gives a lot of advantage, as I've already told. And just see the upper pedicle. This is a thicker pedicle in the upper part. You just find out and see the other clamp. I won't use the vessel sealer here. You can see the clamp. Automatically, this clamp is so designed that you just apply it, automatically clamps and in the proper plane for that. That is a very important thing, and it doesn't question. Just see that it is gone and around, and this is very important. I'm very happy with this type, this clamp. This can serve other purpose also. If you are removing the ovary, you can do that by putting the clamp if you are suturing it. Otherwise, if you are going for the bipolar vessel, then it can be. But putting this clamp and bringing and removing the uterus have served the main merit of the space. You can get a more of space. The other clamp which I have shown you, you apply on the other side. You apply on the other side, but don't think that it is a blind procedure. You just see and apply. Don't see and cut. Don't cut and see. That is the philosophy of the gynecologist. The philosophy of the surgeon is they cut and see. We see and cut. That is the difference. You can the other clamp, you see and see that there is a is properly applied for that, and then you cut it and separate it. Is a 10-12 week size uterus which can be very well done, separated, and the clamp can help in finding out, giving more space, so that we can either suture it, or we can do a vessel sealer for that. So I'm always very, very happy with the vessel sealer. I've forgotten the suture for last so many years. I think this is a boon. Many of the companies have done it, and the Indian companies are also not bad for that. And then the whole thing is out. Then you do the salpingectomy or salpingo-oophorectomy, whatever is possible, and then the procedure. But before the procedure, after the end of the procedure, you just inspect it whether there is an active bleeder or that. If there is a small bleeder also, you can just put a bipolar clamp and coagulate it. Don't go more lateral for that. And this is how even the adnexa can be removed very, very remarkably. I will show you how to remove the adnexa for that. So this is how the anterior pouch is being opened. It's by cutting, use more of scissor and cervico-vesical ligament, you cut it. And in a case where previous cesarean, I think these are the cases where a previous cesarean, you just go laterally. The lateral window of serous set is very, very important. Laterally, there is no adhesions. On either side of the thing, you open it. And now, if you want to open the utrovesical fold of peritoneum is open, if it is easily accessible, then it's good. Otherwise, don't attempt for that. This is the posterior thing, and you just make a incision, it will come out. So anteriorly, you open it, the utrovesical fold of peritoneum, but I have already told that don't attempt in that. And posteriorly, you cut it and you find everything is open for that. So bolt cut, you find that. And therefore, posteriorly, I don't infuse the hemostatic agents for that. And here you can see the laterally, we don't cut it so that the uterosacral and mecanrod are fixed to the lateral wall, the vaginal wall. So you are clamping it, separating it with the attachment of the uterosacral and mecanrod in the lateral angle so that it will give a support for that. And then the uterosacral, this is the uterosacral mecanrods. After the uterosacral and mecanrods, I think the uterus will fall more, descent will be more acute. You find that the uterosacral, then you realize the real support of the uterosacral of the uterus is the uterosacral. Because if you just cut the uterosacral, the uterus will drastically fall down. And that is the significance of the support of the uterus. And that is the vessel sealer can do the job for that. Now, this is a case where the long cervix, and this is a, after that, the uterine is very higher up. This is the uterine ligation for that. You go more closer to the uterus, and long cervix could be a real difficulty in vaginal hysterectomy, but go slow. And this is how you attempt, and the uterine artery, which I've already demonstrated also. So uterine artery, the next step is uterine artery, and both the things, and make a pencil. If there is a myoma, if there is an upper myoma in the upper part, by after uterine you do a myomectomy. But in some cases, when there is a lower side myoma in the lower segment, I think it's not always feasible to do the uterine, and there you can do it in the correct preoperative way. But if after the uterine the myomectomy or debulking has to be done, the bleeding will be less, and that is the main thing for that. And this is the uterine artery for that. Now, this is how the delivery of the uterus, I have already told. Delivery of the uterus is always with the posteriorly. Posteriorly, we get a lot of space, and therefore, we just give a traction, counter traction, and deliver the uterus. That's important. And the upper pedicle. This is how the upper pedicle. I have shown you that this is another thing which with the vessel sealer I have clamped it, but with the clamp you do it is much better than the vessel sealer for that, because we get a more of space, as I have told the significance of this. Second important, there is a chance that there is a current which flows and connects with the vulva also, damage to the vulva. I think if it is bipolar, it doesn't harm, but still there is a chance. But this could be an alternative. You can put a clamp so designed that it will automatically go for that. Now, this is a sulping oophorectomy. People say that even you're removing the ovary, laparoscopy is the approach for that. It's absolutely wrong for that. So removal of the ovary, I think very important. When you're doing abdominal or laparoscopic hysterectomy, you cut the round ligament and then gain access to the infundibular pelvic. Same procedure, same philosophy, we do it with the vaginal. We just hold it with the round ligament, and first ligate the round ligament, or with the sutureless, with the bipolar vessel sealer, you just separate the round ligament, and then you can find the whole of the tube and the ovary. You just grasp it, and infundibular pelvic, you can see it. Only thing is that I always advise to put a gauze piece, to put a swab inside, so that the bowel are preserved for that. Bowel, it doesn't touch the bowel. You can see the behind that clamp, the gauze piece is there, and whole of the infundibular pelvic is visible here. So this can be very well done with that. The same procedure, you can use the clamp and then ligate it also, but this becomes very easy. So vessel sealer is a boon, and this becomes very easy. But at this level, be very delicate, go slow by slow, go step by step, and cut it, and coagulate more, cut less. That should be the principle, because once it goes and then bleeding occurs, it's very difficult to catch it. So therefore, preventive surgery is important, and go slow by slow. And after that, you find that the procedure becomes very easy and very clean. Now, whole thing is out, and you can find absolutely there is a list of there is no bed. Now, same thing on the opposite side. You do it with that, and the gauze piece, you can find that the gauze is there, the swab is there, which is protecting the bowel, and then you can use the suction, you can use the normal saline to cool down effect for that, because at times you do not know that that could touch the adjacent intestine. So now after that, I could find the infundibulum pelvic, you can find the tube and the ovary, and directly you can clamp the infundibulum. This is the infundibulum pelvic. Whole thing is infundibulum pelvic. You can, I'm catching the infundibulum pelvic, and you can see clearly with one stroke I can catch the infundibulum pelvic and then coagulate it, and the whole thing can be out. So remember that salpingo-oophorectomy is feasible, particularly in vaginal hysterectomy. Don't say that it is not possible for that, but remember that this could be possible. But you must go in the right technique with the right instruments, and very, very meticulous thing that you are not injuring any adjacent structures for that also. So this is a way how you do a salpingo-oophorectomy with that. And at the end of the procedure, you can find the whole thing. I say that just go slow, and one by one, if you are very sure, cut the coagulate more and cut less. That is the principle which I am adopting this side. And now you can find the whole of the pedicle infundibulum pelvic is cut, and the whole of the ovary and tube is out for that. So that is the very important thing which I must show, that salpingo-oophorectomy is possible for that. Now the wall fixation. This is the method in which the wall fixation I have told, they are not separated the lateral angle, but the lateral angle we just fix it with that, and the uterosacral we reinforce with the uterosacral and Mecken rod and close it with that. And here what I do, normally I will advise that the 4-layer suture. After that, you catch hold of the peritoneum of the posterior along with the vaginal wall, and catch hold of the peritoneum. You see the anterior also I have catch hold of the peritoneum. I don't leave this. So by that, the pressure of that, if you catch hold of the anterior peritoneum, the vessel, the bladder peritoneum, and with a single layer, and you attach to the anterior vaginal wall. So you take a bite from the intervaginal wall, then the peritoneum, enteroperitoneum, posteroperitoneum, and posterovaginal wall. So you go in that manner. Automatically, you find that whatever little bleeding will be there below the bladder also, that becomes compressed, and you don't get a continuous bleeding for that. So this 4-layer closure is important, and to support the lateral, So one from other side, one from there, and middle part, you keep it open for the drainage of the, if anything for that. In difficult cases, these are the cases of bisection. So uterine bisection and debulking procedure, coring, internal coring, all these are methods to reduce the bulk, so that even bigger size uterus can be delivered with complete safety, with least complications for that. So here there is a myoma. If there is a myoma, it becomes easy. I'm filling the myoma and fixing with the myoma screw with the traction and counter traction. The whole of the myoma can be delivered for that. So this is how you do a myomectomy. But main problem occurs with the adenomyosis. In adenomyosis, there is a transverse beginning, and you find in that particular case that adenomyosis, you go internal coring, and piece by piece you can remove it. So myoma, in big myoma, it can be removed. Remember, always better to do a myomectomy debulking procedure, because if you do not do it, you can deliver the goods. You can deliver the uterus forcefully, but there is a lot of tear, vaginal tear. To avoid that, this is important. The debulking procedure is a mandatory thing. You reduce the size, it's easier, and you can get a lot of space also following the procedure for that. This is again a posterior myoma, and you go through the proper cleavage, and now the cleavage is there. You put a myoma screw, and then find out the proper cleavage is important. If you do not find a cleavage, the bleeding will be more, the difficulty will be of removal of the myoma for that. So if you are going through the proper cleavage, it's important that you can deliver the myoma and reduce the size, and then things becomes very easy, straightforward for that. So this is a method in which big myoma can be delivered it, and then things becomes very easy. The uterus can be delivered after that procedure also. And not only that, but you get a more of space if there is a myoma in the, this is a case where the myoma is in the lower part, so the uterine cannot be approached. Now after that, the uterine artery can be dealt with that. This is a case where again I will show you a big multiple myoma uterus of about 26 week size, and of course vaginal delivery para 2. This is a case where big uterus is not a contraindication for that, a large uterus or vaginal, but you go same thing, the closer to the uterus you go, and whenever you find the myoma, you do a myomectomy and then deliver the things for that. Now I find I did a bisection and find a myoma here. I have then locating the myoma with the myoma screw again. The clamp, you can see the myoma. Just locate the myoma screw. Just locate the myoma and bring it, and ultimately by traction, a big myoma can be delivered in all that. After doing that, another myoma in the right broad ligament aspect, and here we fix again the myoma screw, and with again same thing of traction and a counter traction. Can you see the big myoma can be delivered very easily with that? This is a 26 week size uterus where the multiple myoma, and then you can get, this is the uterine knuckle, you can find it out before uterine. I have done that, and then the space is less, then we can go for the uterine knuckle, and then still then after that I again find another myoma in the upper part, and multiple myoma of the uterus of 26 weeks can be delivered. But and there is a least bleeding because you are going after the uterus is being delivered posteriorly. Again, the last part, there is again a myoma in the fundus and posterior part. Again, I did deliver it, and then a whole thing can be. So it's not, the myoma has become easier than the adenomyoma. But remember, the debulking, the myomectomy procedure, the morcellation, this is important, and you can do it much better job for that. And after that, you can really deliver the big size uterus. So size is not you can as experiences goes, you do from a simple cases to more complex cases, and but the main thing is that you must acquire a particular skill to develop and all that. Now this is a case of a previous 3 cesarean section with the myoma uterus for that. Same, the principle is that cesarean section, there could be injury to the bladder. So remember, the Sirit set lateral cervical uterine space is important. Lateral space, there is a least adhesion there. Midline, there is more adhesion. So go through the lateral space is important. That's a first and foremost thing. And don't go for a blind procedure for that. You go slowly closer to the uterus. You don't find any problem for that. And debulking procedure, same thing procedure after the uterine, after the bladder is being separated in a previous cesarean, things becomes very easy, and that is the only step. You go through the lateral window, and that lateral window we adopt both in laparoscopy also, both in abdominal also. Whenever you are doing abdominally, whenever you are doing a laparoscopy also, that still remains the lateral window you approach, and that becomes easy. So what I mean to say that the cesarean section is not a contraindication for vaginal hysterectomy for that. Scar is not a contraindication for vaginal hysterectomy. It can be done with the 3 previous years. I've seen that in case there is a bladder injury also, you can easily do the procedure, and you can repair the bladder also in layers where this is possible. And this is not an impossible thing. You can do that because vaginally also you can see the margin of the bladder in where there is a cut, and you can clearly airtight closure and do the indwelling catheter for a couple of days, and I think that will serve the purpose for that. So cesarean section is not a contraindication for that. Then at times, this is a case where I was doing that. I was not expecting that there could be an endometriosis, but unexpectedly during, these are all situations where we find that endometriosis. When opening the posterior pouch, I couldn't open it, and therefore normally after opening the anterior pouch, I go for the, normally many people say that if there is a posterior pouch, they open it and then go it. But here the anterior pouch is clear. I could open it. The posterior pouch, I think these are the cases where you don't expect. But I find that loose vaginal wall, but still I find that there is a difficulty in opening. and therefore the whole thing could be a little difficult. But go slowly and close to the uterus, and things becomes very easy for that. And same procedure, I didn't do a separate technique. The same procedure we can do it, and the procedure can be very easily done. So even in endometriosis also, the ovary and uterus, if it is fixed, you can just separate it and do the salpingo-oophorectomy. But the main principle you adopt in that particular case with that. This is another case where the vaginal pathology, the adnexal pathology. The adnexal pathology can also be tackled with that. And remember, these are the cases where the same procedure of anterior pouch and posterior pouch is same. And you just open it and dissect it. Sub-dissection is mandatory for that. Don't have a blunt dissection. The sub-dissection should be very well important. And you go and proper cleavage, gently you go, don't be hurry in that. And remember that this is a case where again there could be a problem. And here we find now you cannot find the posterior pouch opening. So now we see that I couldn't open the posterior pouch because of the adhesion of the endometriosis. And with that, go closer to the uterus posteriorly. At some point of time, you find that the rectosigmoid is free, and we can find at the level, many times you find at the level of the fundus also you can go. But if you go closer to the uterus, there is a least damage to the rectum. And this is a case where in endometriosis, undiagnosed endometriosis, go closer to the uterus and dissect it. At some point of time, you can find that the peritoneum is well seen. This is the uterine. This is the uterine artery which coagulated. After that, you can find the anterior pouch will automatically open. And after some time, you find the posteriorly also you can get a free space for that. So this is a undiagnosed endometriosis which I have found it. If I find that is an endometriosis, I do always a laparoscopy. But maybe that in known cases, in known undiagnosed case where you do not suspect, you can do that. Now the anterior pouch is open. Automatically the peritoneum is open. And you go slowly, and you find that everything is big. So what I mean to say that in skilled hands, you can do more and more challenging cases, even with adhesions, even with endometriosis also, you can do vaginally. There is not a problem. So then go slowly with the bisection technology. You cut it, and internal coring, you just reduce the size of the uterus, and then things becomes easy. This is how you do it for that. Bisection is being done. This is an internal coring. Inside you just, can you see that internal coring and debulking? So internal coring and debulking facilitates the big uterus to be removed. And particularly in a case of adenomyosis, this is more helpful than in the case of myoma. In the myoma, you locate it and then do a myomectomy, that's all right. But adenomyomectomy and other bulky uterus, you can do that so that things becomes very easy. You can get more space, and after that also you can go more laterally approachable and all that. So these are on either sides. We do a internal coring and debulking the procedure for that. So this is how you do the debulking procedure, and after the procedure it becomes very easy. You can handle it. So these are some unexpected situations where you find and tackle it. So endometriosis is not a case where you diagnose. You can see you can see the free area at the level of the fundus, and these cases you try with that debulking procedure. And if you go closer to the uterus, endometriotic, and even in a case of pelvic endometriosis also, you can do the hysterectomy completely. You can do the adnexal removal also completely. So as and when required, you can expect unexpected thing. And these are the cases where you deal with the problem with the good technique and with the good skill. You can deliver the good, and you can successfully complete the procedure with utmost safety for that. So this is one a combination of all the procedures of the vaginal hysterectomy. Straightforward vaginal hysterectomy is one aspect. When the complications are there, when the unexpected thing like endometriosis is there, is also an indication for you can complete the procedure for that. So the same thing I told that yes, with the clamp, you just apply the clamp, the scarf clamp automatically, which will automatically the upper pedicle will be hold with this clamp. Is a very good clamp for that cord clamp, and just after that you cut it, you find a good space, and then you can remove the ovary and tube also if there are other end to the pelvic wall for that. So the lesson and message is that at any point of time you find a difficulty, the difficulty can be overcome by the surgical skill that you acquire, and this surgical skill is very, very important. That's why the purpose of the skill transfer is there. The things are changing, every case is different, and every surgeons are different also. All surgeons have different type of skills. They have a potential, inherent potentiality of good skill, and they can do it for that. So now I can say that yes, this ovary and tube are buried inside. We remove that. After that procedure, we just separate these ovary and tube. These are adhesions which can be separated, and now the ovary and tube can be easily released. So endometriosis is not a contraindication for the vaginal hysterectomy. At any point of time it can be done. This is again a case where we find an adnexal pathology along with the uterus, where an elderly and decided for hysterectomy, and adnexal pathology, benign adnexal pathology, and these I want to show you that yes, if there is an adnexal pathology, vaginal hysterectomy is contraindicated. That's not so. Yesterday's contraindications are today's indications, as I've already told. The same procedure we do it, and the posteriorly also we open up. This is absolutely a straightforward opening of the posterior pouch. You cut it and you can find the opening and all that, and now you can see the posterior pouch is open. The posterior pouch is open. The lateral thing is intact for that. The lateral thing is open because lateral vaginal wall is adherent to the fixed to the uterosacral mecanor, which can be separated so that it forms a wall support also from the beginning without tying. Also, you can additionally do a McCall's procedure or a modified McCall's procedure for another fixation for that. But this, if you separately keep it, I think there is not a problem for that. So same thing we do it with the after the uterosacral mecanor, go for the uterine artery on either side, go slowly, and this is the other side, uterosacral mecanor, and as you go, release the uterosacral mecanor, the uterus will descend more, and that is the support of the uterus which signifies and all that. Now, I've cut the uterosacral. You find that after this procedure, you cut it and then you find that the uterus will be released completely. So that is the procedure where you find that go slow on either side for that. So just release the uterosacral, cut it the uterosacral, and you find the more of descent for that. So that is important, and more of the closer to the uterus is important because the lateral spread we do not know how much. The company says that least lateral spread of about 3 millimeter, but we do not know. This is the uterine knuckle. So if you go closer to the uterus, it's the main principle which prevents the thermal injury. There are thermal injuries which can happen with that, but I have also faced thermal injury. One case I've done that, and fortunately this particular case thermal injury is incomplete, and therefore with the stenting and with the C-arm stenting, the patient can be delivered, and no, I think it doesn't require any extensive surgery of implantation, ureteric implantation for that. So you can see that how this posteriorly the delivery of the uterus is being done as usual, because we get a more of space for that, and some cases posteriorly is much better. In cases where there is a previous adhesions also to the bladder, you deliver the posteriorly before opening, and with the finger you can turn it and find out what is the anterior limit of the bladder adhesions, and from that under guidance after opening it, you can very well demarcate it and cut it so that the bladder injury is prevented, and you can deliver that. You can give a guide by hooking the finger from the posterior to the anterior. The same procedure which the upper pedicle is important to remember that this is a thing which is you just remove it, and then you find what is the over in the adnexal pathology. The adnexal pathology, I find, yes, this is a these are on the left side. I find a dormoid. I find a dormoid which was diagnosed antenatal, the preoperatively also. The sonography was dormoid, and I thought that this could be done by vaginal route. So it's a big bilateral dormoid which can be dealt with vaginally. That is why, that is the purpose of, for which I showed this, is that the normal ovarian tissue as well as ovarian adnexal pathology can also be tackled by the vaginal route, and the skill you develop it, you can do more and more by vaginal route, and that is the main purpose for which I showed this. And after that, it is collapsed. A big even serous cyst, big serous cyst, big mucinous cyst also can be delivered by vaginal route, and this is a technique which can be really adopted, and it's difficult. It's not very difficult, but the only thing is that very important thing that you must prove that it's a benign cyst and all that. So nowadays the IOTA classification has become very important, and very accurate also. I am very fond of this IOTA classification, the benign and malignant classification, and this is important. Preoperatively, you think that it's a benign or malignant, so that imprint also you cannot do it, you don't do it. Then the other side, this is the one, on the right side also, there is a big bilateral dormoid. It was diagnosed bilateral dormoid, about suprapubic lump, about 20 weeks is there, and I thought I will just do an experimental case, and therefore I did this case, vaginal hysterectomy, and there was a adenomyosis. The patient was bleeding, adenocystic cystic hyperplasia was there. Patient was obese, hypertensive, so hysterectomy was being done, and hysterectomy was done, and then bilateral salpingo-oophorectomy was done by this. So this is possible. So why I give a message is that you start from the prolapse to the non-prolapse to the size of bulky 8 weeks, 10 weeks, even 18 weeks, myoma uterus, adenomyoma, adnexal pathology. Go in a ladder wise and acquire a skill. I think everything is possible for that, but utmost benefit to the patient, not to the dogma that you can do everything with the vaginal route. Again, I am telling this. I don't have a dogma for that, and go rationally, scientifically, and all that. And in the era now of distinguishing benign and malignant is more important in adnexal pathology, and therefore this is possible. That's the main purpose for which I demonstrated this particular case and sharing my experience to all of you, that this is possible. You can do more and more by vaginal route by acquiring a skill. That is the main purpose for that. So everything is okay, and after that procedure, the same thing is there. Good wash is there. It's always outside, and then you just close the vault with, as usual, with the left side, with the right side, and keeping the middle part open so that the drainage would be there for that also. This is a case which I have done a hysterectomy. I dared to do the hysterectomy, even if I was tempting to do, because irresistible desire to do it. This was a case of previous myomectomy 2 times, and uterus was 12 weeks. So at that time again a myoma, and I wanted to do this hysterectomy. After doing a hysterectomy, suddenly I find that there was a brinjal seed. I was confused that why there is a brinjal seed here on suction. So I searched for it, and I could find a tear in the rectosigmoid. So rectosigmoid injury could be there, and luckily I could detect this rectosigmoid injury. And after the end of the procedure, you see the rectosigmoid injury is up to 3 centimeter length, and I repaired the rectosigmoid in 2 layers by vaginal route, and then close it, the peritoneum, close the vault. I think this when again I show that these complications of that, you close the bladder injury can be dealt with by vaginal route, and after in hysterectomy, and in rectosigmoid also can be closed with by vaginal route. But the recognition is important. Luckily, the brinjal seed had saved my life, and I could detect it. But believe me, the message is there. If you go to the proper, and if there is any suspicion, you just exclude, find out, do a PR, find out, and all that. In difficult cases, always do a PR examination to find out any undetected injury. And if there is an injury also, don't be afraid of that. You can do it yourself without calling the surgeons for that also. And a good closure, 2-layer closure, and then suturing of that, the patient will be all right for that. I'm sure if you have a good intention, nothing will happen, and the God will help you. And this is one of the cases where complications can happen. You can say, somebody can say that I don't face any complication. That means either they are not doing any surgery at all, or they are the greatest liars ever possible for that. So complication can be there, but minimizing complications could be there. Not that all cases you do it. And once the complication is there, you easily tackle it. Preventing the complications is most important. But at the same time, if there is any complications like this, you can just do it and handle it so that the patient can be. And this particular case, the rectal injury as well as the bladder injury I have found, and with the vaginal hysterectomy also, these cases can be really repaired by you, not by calling the surgeons also, and they can have a good the post-operative outcome. It's not a problem for that. Don't be apprehensive of that. Don't have a fear complex once it's there. And you can see that the whole thing can be very well clear, and you put it on the post-operative for 48 hours parenteral solution, and the 2 layers can be very well repaired. The single layer and the second layer, I'm going it for that, and this can be very well tackled for that. Now, ladies and gentlemen, my viewers, my Juventus partners and all that, that is the end of this session of episode of this. And before ending this, I must say that I am now a satisfied soul. When we formed a society, that was a dream of mine long since, when dealing with this Dr. Siriseth, Dr. Shonawala, and the pioneer Indian surgeons, vaginal surgeons. And then we formed a Society of Vaginal Surgeons of India, SOPSI, in 2018. 2018, the SOPSI was being formed in Bhubaneswar with the founder president, Professor Siriseth, who is one of the founder of vaginal surgery and vaginal hysterectomy. For that, when patron Professor Sonawala, and 5 vice presidents in 5 zones, veteran Professor Paili and Dr. Ava Singh and Mira Agnihotri, and 5 and Arun Bhada Barua. These are the things. And Honorary Secretary General, none other than the most dynamic Dr. Hara Patnaik. Hara Patnaik is now the Secretary General for that, and President Professor Siriseth with the 5 vice presidents and all that. And I had a dream of forming this society where we did it. I told that I will be just a silent observer, and I will enjoy my life in the last part by doing a society for that. Now, after forming the society this year, we are supposed to start the live workshops, but Corona has affected. And during the Corona pandemic time, I got a lot of requests from the various states that you form a state chapter. And all states have formed a state chapter: Maharashtra, Kerala, Karnataka, Northeast, all societies, Delhi, everybody has formed a society, and the state chapters are functioning very well. And we are doing every month one of the programs in vaginal surgery, and there are a lot of people who are really interested in to join the society. I welcome all gynecologists who want to do have a little interest in vaginal surgery. Join the society, SOPSI, Society of Vaginal Surgeons of India. And this society is there to guide you, to teach you, to learn you, and to involve you in all activities for that also. And I say that if any other query is there, you talk to Dr. Haraprasad Patnaik, our dynamic Secretary General. He will tell in detail. And I just wish long live SOPSI. And I welcome everybody, that those people who are interested in vaginal surgery, including hysterectomy, non-hysterectomy, prolapse, everything can be encompassed with this society. I got a tremendous response, and now I will live in peace till my last breath. And today I thought that when I'm speaking on vaginal hysterectomy non-descent, I think this is a forum, SUBSI, I must remind. I salute this organization, SUBSI. I salute everybody and welcome everybody to create an interest for the benefit of the patient, for the really minimizing maximizing the benefit, minimizing the invasion. I think that should be the era now, and this could serve the real purpose for that. Thank you very much, ladies and gentlemen, for giving me this opportunity. And thank you, Dr. Devan, Alad, and whole team of Juventus for continuing this. And I was just thinking 10th episode is going on there. I congratulate my viewers for that. And therefore, the viewers' enthusiasm, the viewers' stimulus has given me life again. I thought I was an expiry date person, an expiry date teacher. Now you have made me alive for the second time, a second life. I think I will continue to have it till I get a response for that. Thank you very much.
Sir, thank you so much. And for us, you will always remain evergreen. And you are actually evergreen person. Yeah, tremendous stamina and tremendous blessings are there from the Lord with you, sir. So we wish you a very, very long life and a very stable, career.
Thank you, thank you, thank you, thank you.
Sir, and we wish you a very good progress in this particular society, a Society of Vaginal Surgeons of India. And we hope that this society progresses and helps the surgeons in getting right path and helps them in newer techniques.
Dr. Diwan, I can inform you that Juventus has initially planned that we'll do a live workshops across the country before the corona. We are just starting it and this problem occurred. And I need your support.
Sure, sir. We are there with you. Definitely, sir. We will help you. Okay, sir. Now with this, we have a few questions, which like today, my colleague, Dr. Sanjay Navle is also there. So I would involve him also in asking a few questions. And to begin with, first of all, there are a lot of compliments pouring in from all directions for you, sir. So I, would rather focus at this moment for the queries which are specifically there. Like Dr. Vijayalakshmi Kandasamy from Chennai, she's asking which electrosurgical clamp are best for purchase.
Pardon?
Which electrosurgical clamps?
Laparosurgical?
No, electrosurgical.
Electrosurgical. I think electrosurgical clamps, the basic unit is important. What the clamp is different. They are very intelligent. The all companies are intelligent people. One clamp cannot fit to the other things, and rarely there are some excepting a few clamps which fits to the other. But usually they have their own clamp with their own set of instruments for that. Right. But the instrument choice of the instrument should be good. And I'm happy with the Martin, with the RB. I have dealt with all these, and even with the Indian also, I'm happy with Alan also with that. Right. Because they have got a different advantage of Indian companies have a shear system, which the other people do not have a shear. They cut it with automatically the tip also cuts it after coagulation. So it's your choice, your purse and all that will, and your bargaining capacity also at the last.
Yeah, Dr. Navle is going to ask you a question from Dr. Bharti Uppal. Dr. Navle?
Sir. Thank you, sir. Thank you very much, Mahapatra, sir, for your very knowledgeable session and valuable tips for the vaginal hysterectomy. There is a question from Dr. Bharti Uppal. She is from Delhi and she is asking the difference between Weimard, Wardmeyer's and Hines hysterectomy techniques.
Pardon?
Hines and Wardmeyer's.
Hines and what? See, Wardmeyer's is different. Wardmeyer's is a vaginal hysterectomy with pelvic floor repair. And when Ward and Mayo has designed this, there is a specific purpose. It must be a procedentia. It must be a atrophic uterus. And you do a hysterectomy, vaginal hysterectomy with pelvic floor repair. I just clarified before that the previous session we dealt with the prolapse, pelvic prolapse and POP and pelvic organ prolapse, where in addition to the hysterectomy, you are going to have the support of the pelvis, repair of the pelvis. So that's why from the beginning I said NDVH versus vaginal hysterectomy. When we say that vaginal hysterectomy alone, it implies that there is a non-descent. And Hines is a non-descent. Without any descent also, Heaney's technique could be there. But Wadmayo is always with a descent and precedencia.
Right, sir. So there's another query from same like Dr. Kandaswamy, Vijayalakshmi Kandaswamy from Chennai. And she's asking like, what about bleeding from vaginal cut edge? Your videos are so bloodless.
No, bleeding from cut edge. See, if you are giving a complete equidissection, both anterior and posterior, bleeding will be absolutely least. But I don't give a complete equidissection. I give just a 20-30 cc maximum on the anterior aspect and 3 o'clock and 9 o'clock. There is some reason behind it, because posteriorly I don't infiltrate that. Posteriorly you can also infiltrate. The only problem is that with one cut you cannot go and reach the peritoneum, because if you're infiltrating, the thickness will be there and you are confused where is the place. Maybe that after some point of time you can get the peritoneum for that. There is no harm in it. But remember that if you are infiltrating anteriorly, leaving posteriorly, that gives an edge that you can open up the posterior much better, and you can directly open the POD, the cul-de-sac for that. And I think it's not my videos and all that. You can do much more. You can do a bloodless surgery also if you infiltrate, but don't give more of that. Vasopressin you can give it, or simple vasopressin is costly. Adrenaline 1 in 1 lakh. You can give it in dilution. One drop of the adrenaline can be infused with the 100 ml or 200 ml of normal saline. You can infiltrate. That's not a problem.
Right, sir. With this, that's the end of the queries today. And we again thank you very much for your nice and excellent deliberations, sir. Thank you so much.
Thank you very much,
Thank
sir.
you, Dr. Dewan.
Thank you,
Sanjay.
Thank you, sir.
Thank you.
Thank you, doctor.
Thank you.
Support, please.